Time for about 10 minutes of questions. So the floor is now open. There's a microphone there. If anybody has questions of any of the panelists, please.
So I represent people with this cancer, and something that one of the doctors brought up is a question that I probably am not framing very well. I'm a political science person, not a medicine person. But what I'm seeing with immunotherapy is so exciting. It's not just longer life, but real life. But I'm seeing a lot of my clients are being required to do the chemotherapy or the radiation first. And I saw one of your data points were showing the results after all of those things were done. And I'm just curious, and it might just be that it's too broad because there's so many types and genetic components that relate to it. But do people need to go through those other treatments before jumping into immunotherapy? Or, I mean, a somewhat jaded perspective is that might be an insurance requirement and not really with health. So that's my awkward question.
The immunotherapy results I have shown is the selected patients selected for the clinical trial. So that cannot be immediately generalized to the entire patient population unless we go through the next steps in the science and show that actually benefits. The immunotherapy currently that is approved, which I will refer to Dr. Gomez in a minute, is the body immune system already recognized mesothelioma, trying to kill it, and the mesothelioma cancer is fooling the immune system, putting a brake. Mother Nature built up a nice brakes on our immune system. If I hit my hand, all my immune cells will come here, it's inflammation. But if they keep on going, I'm going to die. So the brake immediately comes on, the gas pedal and the brake, once you press the accelerator, the brake comes on. So the immunotherapy that is approved is taking the brake away and let the immune cells keep going to kill the cancer. Not necessarily all the patients have enough immune cells if we take out the brake to kill the cancer, and that's where we are doing with the CAR T-cell therapy. So immune system is different from each patient. It's a different stage. So immunotherapy has to be strategically applied to a selected set of patients, which we are not there yet. We are getting there. And why to go through chemotherapy rather than just give immunotherapy? Again, there are differences and the results are different between chemotherapy and immunotherapy. I'll defer to Dr. Gomez to talk about the approved data.
So the way that is structured is not so unusual or abnormal. If you look at the studies that compare chemotherapy and immunotherapy, in the majority of patients, the patients with epithelioid mesothelioma, there is no difference in terms of how well it works. Now, that doesn't mean that it's not different. Some of those responses, those massive responses where the disease disappears completely, even in patients with epithelioid mesothelioma, that hopefully in the future will make a difference because that doesn't happen with chemotherapy. But if you look at all of the patients with epithelioid mesothelioma, immunotherapy isn't better than chemotherapy. And so either treatment is appropriate. And you know, it's unclear right now which one you start with because we really don't know who is going to benefit from immunotherapy. I think that's the issue. So it's not so unusual.
Good morning. George Friedman Jimenez, Bellevue, NYU Occupational Environmental Medicine Clinic. I have a question for both the radiologists and the surgeons. In the Libby cohort, has there been any opportunity to correlate the imaging with gross or micropathology that you've had opportunity to do surgery or biopsies on any of the patients that have had imaging that looks like plaques? To answer this question, which would seem to be a fairly straightforward hypothesis to test, has anyone presented that opportunity? Any patients from Libby that have required
so there's several
pathology?
publications looking at correlating that are out there from the Libby group that correlate it. The thing that's interesting about these patients is when you're there and you actually have the patient in front of you, you look at the CAT scan findings and it's minimal or not impressive. And then you see the patient where you see that little lamellar thickening that David's talking about, and that patient has excruciating pain here. Their shortness of breath is at a proportion to what you're seeing on the scan. And the thing that's horrible about it is that Libby's known for lung cancer, mesothelioma, but very few understand that a significant number of Libby patients actually die from benign disease, from progressive pleural fibrosis. And that's very underappreciated in the Libby population.
Yeah, I mean, the number of cases where we have direct pathology correlation, it requires a lot of coordination, taking pictures, and there's only been, it's not a terribly complete series. What we do have, though, is we have lots of cases where we have the progressive CT scans over time, and we've been able to see how the disease progresses. And so, when you see these plaques get bigger, and so when you see them getting bigger and you look at the year before or whatever, you can start to see the changes a bit more concretely, so you can be much more certain of it. So that's most of what we have.
All right, great, thank you.
Younger people and women have such a poor survival compared. And I wonder if it's the time from when they're actually diagnosed, so that they're not diagnosed for a very long time, because no one's expecting them to have mesothelioma at a young age, and women no one's thinking the women have mesothelioma, so that they have a very long pre-diagnosis time, and that could be skewing the results, or do you think it's something else, or both?
At this point, the scientific answer is I don't know. We were surprised by the results. I think what we have seen is the tip of iceberg. Perhaps there is a combination of genetic predisposition and exposure to asbestos, and that educating us, it's not the length of exposure, it's not the duration of the exposure. If they have a genetic predisposition, I can only guess perhaps even the smaller exposure, because most of these patients in the database are not long-term exposed. But this gives us a next step to look into. And as you mentioned, I really appreciate elaborate occupational history when we see these patients. Because if I just asked what their occupation, I wouldn't have got all the history of their exposure in my clinic. So I think now increasing the awareness that a young patient, especially in a community service, veteran or military cops or firefighters, if they have unresolving lung symptoms, we must take this detailed history, and that will help us to look forward. So,
one comment, one question. Dr. Gomez, hope is important to the entire family. And so I appreciate you bringing that point up, because that is actually part of the medicine. The question is, after immunotherapy ceases to work and disease has progressed, have you found the trend to be with those patients that cancer returns and it's so aggressive there isn't any more treatment? Because from the patients I've interacted, that seems to be the trend and path.
No, we really haven't seen that in general when the disease begins to grow again, and it may take many years for the disease to begin to grow again with immunotherapy. It comes back fairly similar to what it was before, and so it does give us time to do other forms of treatment.
Encouraging. Thank you.
I have a question about these lamellar plaques. I was not aware of this. I think that's a very interesting finding. And have you noticed change in lung function that correlates with the progression of the pleural disease? That's question one. And question two is, round atelectasis is really an aggressive pleuritis that, as you know, that just grows in and invaginates the lung. Are there any similarities between this lamellar pleural thickening and that?
So first, I wanted to just say one other thing. One of the reasons we don't have great histologic pathologic correlations is that you don't operate for these subtle pleural plaques. These people don't necessarily go for surgery. They go for surgery when they have lung cancer. And so even though the lung cancers are relatively high, not all the patients with lung cancer have lamellar plaques. So it's not as frequent that we get autopsies from other causes of death. Yeah. No, they've been trying. They've been trying to put these together. The round atelectasis, yes, round atelectasis, we see a lot of round atelectasis with the Libby group. It's not necessarily associated with just the lamellar plaques. They get it round atelectasis with all the asbestos diseases. And the Libby doesn't only get lamellar plaques. They get the other plaques too. They get sometimes big, thick plaques. They get diffuse pleural thickening, that really very thick rinds that cover the whole pleural surface. They get pleural effusions. The lamellar plaques are a subset of the plaques that they get. And it has just a very different appearance. As I said, they're very thin. They can be stop-start, like layers. They tend to spare the costophrenic angles, certain features of them, and they cause enormous pain. They cause a lot of restrictive lung disease. That's part of These people can't breathe. They're in agony.
And so you do see changes in lung function as.
Oh, yes. Yes. Dramatic changes in lung function.
And there's no evidence that they invade the ribs in a way that would.
No, the plaques don't invade. The plaques don't invade.
No,
They're associated with a lot of other autoimmune features of the illness, but they don't invade. They're really thin, involving just the pleura, not invading anything.
That's very interesting. Thank you.
So that amphibole that you see in Libby is throughout that region, all the way down to the Las Vegas, Arizona. So when you, for example, they say when you ride a motorcycle and you stir up the ground, you're stirring up the same type of dust that causes these diseases.
My name is Angelo Garcia, Future Environment Designs. I train asbestos workers, and Dr. Markowitz made a comment about that, and I'm not sure if I heard it right, so that's really the question I'm asking. I've been telling my students that they should probably go for CT scans because obviously lung cancer can be found quicker with a CT scan than an X-ray. But I got the impression that that doesn't work with mesothelioma.
Yeah, so they once they reach a certain age, they should have the low-dose CT for lung cancer. And the side benefit of that is that the radiologist is obviously going to look at the pleura, look for any evidence of fluid or whatever, any signs of mesothelioma. So it's the same test.
Okay.
So one doesn't have to distinguish what the important outcome is. It works for lung cancer. It's not been proven to work for malignant mesothelioma, but you need to have the test in any sense.
Thank you.
This is the plea, really. So as a lawyer dealing with asbestos diseases for just under 30 years, the defendants these days, the companies we're suing, they're regularly saying, they're talking about safe. Your client couldn't have got mesothelioma or any of us, whatever disease I'm dealing with, asbestos disease, because he wasn't exposed to enough exposure to asbestos. So we're having safe limit. So they're basically saying there wasn't enough, he wasn't exposed to enough fibers to have caused this disease. So it must have been environmental, idiopathic, whatever. So they're the arguments we are constantly having to deal with in courts. So they're trying to prevent victims of mesothelioma or any other asbestos disease from receiving their compensation. So what I would like you guys to do is, because you're very eminent here and you've got so much experience, is IMIG is coming up in Philadelphia in October. It'd be great, because I did actually ask this at the Lille conference. I would be grateful if you could request your medical colleagues it'd be great if IMIG could put out a statement saying that all the asbestos is dangerous. There is no safe limit. And I'm also asking if they could specify that there is no safe limit to chrysotile asbestos. That's very important, because in India currently, I'm working with an Indian lawyer who's trying to deal with asbestos in India, trying to say that it's dangerous. And he has also said, is there a statement which IMIG or any other professional body can put out saying there is no safe limit and at all? When I did ask this question at IMIG, I was told that the medics don't want to get involved in politics. So is there anything you guys could do, please?
I'll just comment that there is no known safe level of exposure. The problem with chrysotile specifically is that there's no known chrysotile-only exposures with 1 day of exposure. We know that for the other fiber types, that 1 day of exposure. So, I mean, you can't get lower than that. There was even a case in Australia, 6 hours of a mechanic who repaired some equipment in an asbestos factory. the data doesn't exist the same way for chrysotile, but there really should be no difference. And again, it's what the science tells us, and especially in places like India, where I've been traveling for 20 years, more than 3 dozen trips now. You just have to fight the misinformation and get the truth out there.